Me too. Me too.
Jedno evo, evo, jeste mi nigde gdje mikrofon kreće. Jesmo li?
Oh wow, I love those.
So have you found your seats? So good morning to all of you, and welcome to the second day of JACP meeting. Today's day is all about personalized healthcare, and without further ado, I would ask kindly Professor Joseph GLIGOROV, who is walking away. Yes, that's okay. To take the stage. Here you are. Oh, you have it. Okay.
So thank you. It's my pleasure to be here. If I understood well, we have 45 minutes. I was thinking that we have 1 hour, but in any case, I will go through. And my speech is devoted. You asked me to speak about the personalized healthcare in oncology, right treatment to the right person at the right time. So it's probably what is the future of oncology. It was not only the future, it was also the past, but what was the evolution of this point is very important, and I will focus on two parts. One is kind of more, let's say, general, historical, and ethical approach, and the second one is taking some examples to show you from where we are and where we're going here. I would like to thank the Roche company, and particularly Eric Barrière, who is not only a medical doctor, but a friend of mine, and we are involved together in different, let's say, plans of development of personalized medicine since close to 10 years, actually. So these are my disclosures, and I will begin with what I've called the historical perspective and the concept evolution. The first thing is, when we think about the diseases, I would like to begin to mention this. This is ancient Egypt, and this is the first time, 27th century before Christ, that disease as a disease was mentioned. That means that it was not before, and that the humanity do not have, let's say, the conscience that it's as a disease, but it was clearly stated as not only a part of human being that might be, but also that some people may be devoted to treat patients or treat person that have some particular diseases. And then I would like to also mention a second very important step in the history of medicine. It was in Babylon, in Persia. This is 20th century before Christ, when in these tablets, the diagnostic and book, the first time was written first, what is the diagnosis? Second, what is the prognosis, which is part of also kind of personalized medicine. 3, what are the physical examination criteria that you need to do to just give the diagnosis? And then also the beginning of the treatments that might be important for some diseases. But the main new concept that we have comes from Far East, from Asia. And this is written in some very important, let's say, approaches like the Ayurveda medicine. The philosophy is very important because this was the first time when was stated that, as you see here, health and disease are not predetermined, and that potentially life may be prolonged by human effort. So this is the first time when humanity is opening the door saying that we can potentially modify the evolution of what is actually the outcome of a human being, and that it's not only destiny. So back to that, you know these guys probably, Hippocrates and Galen, coming from the, let's say, Greeks and Romans periods. And you might have the slides if you want. You can take the picture, but I will let you the slides. And the first medical school came even before the first university, as you will see, because the first medical school was in Salerno in the 9th century, and was clearly devoted not only to to treat patients, to treat sick people, but also to begin to understand what are the different canons of medicine and how to just educate the future of the doctors. Then we have the first university in Bologna, and just to try to resume this historical, very short and brief point of view, the first thing is that we have moved in the last 30th century from what was a destiny to causality, which is clearly a progress, because trying to understand what happens will help to understand how to treat. The second thing that we have moved from palliative to curative, and this was also a very important step that was impossible to achieve if we have not moved from destiny to causality. And this is also a progress. And the third thing that I think is also very important to integrate is that we have moved from patient-oriented to potentially disease-oriented treatment and taking care. And to be honest, I'm not sure that this is only a progress, because we have to go back and integrate the position of the patient in the general global strategy of treatment. The second point that I want to mention, historical point, that it was a long way to oncology to become this very, very important, let's say, epidemiological disease. And why it was a point? First, it's not a modern disease. Here you have just the examples of pretty recent publication of prehistorical data that show that even at that time, potentially, some human beings were suffering from mets and probably from cancers. So cancer is not a new disease. When you just listen that it's amazing how much cancer we have actually, it's not because it's a new disease. It's because we have to move from several periods of history that have made the humanity dying of different disease before, let's say, the cancer will begin and become very important as an epidemiologic point. The first thing is the infant mortality. And you have here the example of what was in France, the infant mortality in the 18th century, and actually you see the dramatic decrease, which was the first step to try to improve the overall survival of the population and the way that people might live longer. The second thing is the misery and starvation. If you don't have food, if you don't have money, if you don't have a basic economy, you will not suffer from cancer because you will die from other things before. So this is the second thing. So that means that if you have an increasing rate of cancers, that means that probably the economy do a little bit better than it was before. It doesn't mean that it's perfect, but it was, in any case, better than it was before. Then the third thing is the evolution of what is the life expectancy among the period of the 19th century to nowadays. And just to show you the different eras that were described by the specialists who were involved in the history of medicine. The era of plague and starvation that I mentioned just before. The era of the decline of pandemics, which is really important, so the infectious disease. Then the era of degenerative and societal disease, which is clearly smoking, drinking, and these kind of things. And finally, the cardiovascular revolution that makes possible the people will live more than 60 or 70 years, and then let the cancer became one of the most important diseases that we have regarding the epidemiologic point of view. But also what I want to mention, I know that we are not here to discuss about the infectious disease, is the impact of the preventive medicine, and particularly the vaccines, regarding the risk of death to infectious disease that you have from 1888 to nowadays. There's two messages. One is that all you're reading about the vaccine is usually bullshit. I'm sorry to say that, but you have to be very careful, because actually we have, in some countries, kids that are again dying from various infectious disease. Okay, so if you don't want to go back to what was the history of medicine 200 years before, be careful about that. And the second thing is that, as it is for infectious disease, the best way to treat cancer is to prevent it. This is the best way you might have a clear impact. So what happens is that the incidence of cancer is actually growing up, as you see here, worldwide, in usually the more developed countries. But in the countries that are on the course of development, or let's say less developed countries, the incidence is even higher and will be higher than it is actually in the more developed countries. So that makes that some years before, maybe you have read this book, Siddhartha Mukherjee published this book, The Emperor of All Maladies. It's Emperor of All Maladies because the majority of the maladies that have killed humanity before have been, I will say, for some of them treated, eradicated, and the other one controlled. The next emperor of the malady will be the neurodegenerative diseases, when we will win I will say, the war against cancer. The third point I want just to do as an introduction, I'm sorry we're not discussing strictly about personalized medicine, but I want you just to look carefully about these points, because my point of view is that we could not discuss about personalized medicine if we do not understand how was the evolution of what cancer means and what the disease means. The third point is the definition and the evolution of cancer as a disease. This is the epidemiology data from the beginning of the last century, 1930, just between the two world wars, and nowadays. And you see that some of the cancers, like here the lung and bronchus cancer in male, not in female, and some other cancer like stomach cancer have decreased. This is due probably to some clearly social improvement and not treatment improvement. This here is due to clearly modification of the inhabitude of smoking, particularly in men's and less in women's, because actually, as you know, the most important, I will say, cancer that will give the highest mortality in the woman worldwide is considered to be breast cancer, but probably in the very next future, it will be lung cancer. Then, what happens regarding the definition of cancer? And this was published in Journal of Pathology, which is a very important journal for the pathologist, some years before. This is the last century and the different hypotheses regarding how cancer became a disease. And you see that the different theories that you have here are just following the progresses we have regarding the biology and the technology. At the time where you have just a microscope, you will say that it's a disease of some tissue. At the time when you have more modern technology, you have identified DNA, you have identified proteins, you will clearly define cancer not as a disease of an organ, not as a disease of a tissue, but potentially a disease of a cell or particular abnormality in molecule. And this is the evolution of the different theories we have. That doesn't mean that all these theories are wrong, the oldest one, but some of them have been implemented, some of them are not actually clearly good theories. But that means that at any time of the progresses, scientists and, let's say, doctors have think about what is the causality of cancer. So let me now go back to very simple definition. Probably some of you know very well that. I'm sorry for those who know, but just to remind you that we have all cells. We have several billions of cells. And in the nucleus of the cells, we have chromosomes. On the chromosomes, we have genes, and this gene will code for proteins. And without proteins, you could not have any function and action in your cell. And this is not only in the developed organism, but also in the basic one, in the bacteria. The only organism that might live without this mechanistic complexity are viruses, but then they enter into the cells and they will use the mechanistic complexity of the classical cell that we have, the eukaryotic cell, and then became aggressive. The thing that I want to define to you is what is the difference between a normal gene that you have here that will code for a normal protein and what we can say a mutated gene. So you have here a mutation on the DNA, and this mutation might give two different kinds of information. One is that you have an abnormal protein, You still have a protein, but it's not exactly the same. Sometimes you have mutation, and I will say even the majority of the mutation will give the same normal protein, or some modification will give no impact of the functionality of the protein. And sometimes you have mutated genes that will clearly no more code for proteins. So you will miss one protein. If the protein is crucial for the development of the organism, you will not have any kind of life. So that means that some mutation that you have in the embryogenesis will not lead to go to classical development of the fetus and the kid. Then we have other type of abnormalities in the chromosomes and in the genes. One is what we call the chromosome inversion. The chromosome inversion means that some genes have been modified regarding the place. This one is here close to what we call the centromere, but now is far, and this one, what was far, is closer, okay? This kind of modification might also impact when you just copy the chromosome and you want to code for a protein, the type of the protein that will be expressed. The second thing that you might have is what we call the chromosome translocation. You take one part of a chromosome that you will put to another one. And this could generate, for example, a new protein, and I will give you an example. And the third one might be a gene amplification. You have here one gene coding for one protein, you have here, and then if you amplify this gene and you have increased expression, you will have more proteins. I will not mention in the second part, but this is typically what happens when you have HER2 positive breast cancer. You have one gene that has been amplified and you have more proteins, okay? And this is what I mentioned to you, the mutation with a normal protein or potentially an altered protein. And the last point I want just to check with you is that on the evolution, on the normal evolution, I will say, of cancers, usually what happens, and particularly those cancers that have pretty long evolution, you have an accumulate rate of mutation. A first mutation, a second mutation, a third mutation, etc., coming to a malignant cell tumor growth. What does it mean? It means that sometimes, if you get the information here, you will have this mutation information. If you take the information here, you will have another one. And if you take the information here, you will have a third one. So that means that the evolution of the disease under treatment pressure or not might make the identity, the biology of the cancer a little bit different or totally different from what you have at the initial stage to what you have on the metastatic disease. Is it clear to you? Yeah. Okay. So this point regarding the rate of mutation was emphasized by Bernd Vogelstein, which is one of the most involved scientists in the evolution of the theory of carcinogenesis. And Vogelstein mentioned that if you look here, what we call the stem cells, that are the cells that are in all the organ, very important to, let's say, assure the stability of the organ and the regeneration of the organ. If you look at the number of total stem cell division, according to the organ and the lifetime risk, you see that his theory is that the more you have stem cell divisions, the more you have risk of cancers. So he clearly correlates out of taking the, let's say, different carcinogenic chemistry or carcinogenic, let's say, influence that you might have, like smoking or other one, but for those who are non-smoker, for those who are not taking particular drugs, you see that there is a correlation between the number of cell divisions and the risk of having a cancer. The more you have cells that will divide, the more you have risk of cancer, because the more you will potentially accumulate abnormalities in the genome of the normal cell, what was a normal cell at the beginning. This is a theory. But there is also a very interesting thing. The more you have cell division potentially, the more you will have also what we call the somatic mutation frequency. What does it mean? Here are the different types of cancer that you have, coming from the neuroblastoma to the melanoma. Neuroblastoma here on the left side and melanoma on the right side. And here you have the rate of somatic mutation. And you see that the cancers are different regarding the rate of somatic mutation. There are cancer when you have a lot of somatic mutation, and there are cancer when you don't have too much somatic mutation. So now if you look carefully at the name of the type of cancer that you have here, those are usually the more immunosensitive cancers. The more you have mutation, the more you have new proteins. The more you have new proteins, the more you will probably express these new proteins to the tumors, to the cell surface of the tumor cells, and potentially begin to induce an immune response. The point is that the immune system failed clearly to control this. And this is why in this type of cancers, lung, squamous, melanoma, bladder, head and neck, etc., you have more impact of the immune checkpoint therapies, because you will just reverse the capability that the normal organism have to control the immune response and try to target the neoantigen cells that are expressed on the tumor cells. So this is another consequences of the mutational rate, and you will see what might be the implication. So I'm mostly breast cancer specialist, but I would like just to focus here of what was the evolution of how we just defined breast cancer the last years. This was at the beginning of the, let's say, last century, the classical breast with the tumor that you can see here. Then we defined the histological type with a microscope, with ductal and lobular. There are several other ones, but these are the most important. Then the grade, we just try to define, just describing the tumor cell if they are not very aggressive or aggressive. And then we have integrated the last 40, 50 years new markers, which are, one, the expression of the estrogen receptor, two, the overexpression of HER2, or the amplification of the gene, and three, some molecular subtypes that have been defined using classical NGS approach or new approaches that are actually under validation. But in any case, that means that since 1970s, all women treated for breast cancer were treated exactly the same way. And since 1970s, we have introduced drugs like tamoxifen, targeting the estrogen receptor, trastuzumab, so Herceptin in the 1990s, 2000, and pertuzumab and the other one, and actually trying to better understand the molecular profile of these cancers, we're trying to integrate new drugs. The molecular classification is, first of all, a prognostic one. What does it mean? It means that we know, according to the expression, to the amplification, to the mutation rate of some different subtypes, which are the more aggressive or the less aggressive. And you see here that some of the cancer, the deep blue line here, are with very good prognosis. This is a percentage of patients that are still alive without particular treatment at the beginning. And these are the patients that are still alive if they have not been treated with the right drug at that moment. And here, the pink one are the HER2 positive. This was before the era of targeting HER2. Actually, the curves of the HER2 positive patients are even probably same or better than the other one. When you focus on a specific target, particularly on a group of very bad prognosis, you might have excellent results. This is a goal, clearly the first goal of what is called the personalized or the precision medicine. Try to identify the bad prognosis group and do better. There is another option, which is saying this group is doing not so bad. Maybe they don't need too much treatment, and we can just desescalate and use less treatment. This is also another way of personalized medicine. But actually, in the majority of the cases, because we have still patients with very aggressive disease, not only in breast but in other cancers, the main goal is to identify people that are doing not so good, that have target, and we can target these anomalies. Another example, this is ovarian cancer. This is an ovarian cancer that you can see during the cilioscopy. Then the integration of the histology that you have seen here, according to the different type of cancer. Epithelial one was the most important. Then we have tried to better identify what happens with the tumor cells here, with the type 1 or type 2, as you see. But then we have some characterization of mutation that are P53 for the type 2 epithelial ovarian cancer, and other type of genomic alteration that are more clearly in relation with the type 1. Prognosis, but also potentially for some of them, like PTEN, PIK3CA, RAF, for example, they are clearly actually targets for new drugs. So this is why you have to understand that the targets that we are identifying are just the consequences of the improved technology to better characterize the different tumor types. But what makes the situation more complex, and this was a publication a few years before in one very important medical journal, New England Journal of Medicine, when you take a patient with lung cancer, and when you look at different, you see this is a cancer here, and when you look at different part of the cancer, you can see that you will have different gene alteration, different kind of mutation, explaining that using some drugs, if you destroy this clone or this clone, you might select this one that will continue to grow if you don't target it. So the complexity of the tumor is that at the end of the day, the tumor have exactly the same goal as the patient, to be still alive. And that makes the problem. So the way we have identified different targets was in the process of, let's say, two very important publications by these two guys, Hahnemann and Weiberg, which are maybe the future Nobel Prize in some years. And they have clearly identified different pathways that are very important for the tumors to be still alive and to continue to be aggressive. This was the first publication showing that there is two things, always. The cell is exactly like you and like every human being. When you are in a situation of stress, if you take the extreme situation, you have two options. One is to continue to fight, and the other one is to die. Dying is apoptosis, is what we call the cell suicide. And continuing to live is to promote the proliferation. Okay? You can see the humanity is exactly the same thing. When you are in a very poor country, you have more children. Proliferation, that's life. Because the only way you want to show that you can live is to make kids and to try to do your best to build some future, even if it's not maybe the right way. And when the situation is very bad, so the only thing that you can do, it's a general suicide, economic or whatever you want. Same thing on the cell. Resisting cell death or eventually inducing what is here apoptosis. And then you have several pathways that are very important. Among them was angiogenesis, controlling the vasculature of the tumor with different drugs that you probably have heard about. One of them is bevacizumab, but there are many of them that were in development. But the new presentation of the target was published in 2011 by the same team, and they find that there are not only 6, but even more. And I just put here some very important actually application or consequences on treatment for the patients. The green bar that I've put here are clearly drugs that have been developed when you have alteration on the tumor cells, focusing on, for example, the control of the evading growth suppressors, control of the proliferation signaling that you have here, or control of the apoptosis that you have here. Then you have other that are focusing on what is the environment of the tumor cells, which is a little bit more convenient if it works. Because the environment is more stable, you have less genomic alteration. One is clearly the immune checkpoint therapies, what we have discussed before, when you will just help the immune system to control again the disease. And the other one that you have here on the red are the angiogenesis targeting drugs. And there is also a new approach when you have some germline mutation, that this germline mutation will be in all the cells, and you will use this germline mutation as a potential tool to emphasize some genome instability and push the cell, the tumor cells, to suicide. So you will take what was the advantage of the cell at the beginning, because they do more proliferation and more mutation, and you will just say to the cell, okay, continue this way. But there's too much mutation for the cell to be still alive. So it seems risky at the beginning, but at the end of the day it works, because you will kill then all these cells because they could not survive with this amount of mutations, okay? But this works just actually in BRCA mutated population. What makes the situation more complex is if you look what is the human prostate, let's say, cancer cell, and you see all these proteins here that have been coded by different genes, they might be, for the majority of them, involved in the mechanism of resistance of the classical treatment of cancer. And this is just for one cancer and one type of drug. So what makes the situation difficult is that at the end of the day, as I say to you, you have to summarize this. And to summarize, there are two very important pathways that are actually activated or mutated, and that are controlling two things: the survival and the tumor death. One is what we call the RAS-RAF MAP kinase pathway. The other one is PIK3CA, AKT, mTOR. And what happens is that if you have a mutation here on the RAS pathway, that means that you will have an activation of the survival genes, and whatever you do, actually, the cancer cell will have the signal of stay alive. So it's why we're actually working on this part and this part of the pathway, which is complicated, because these pathways are regulated not only the tumor cells, but all the normal cells you have in your organism. So the last part that I want to focus on before giving you some examples is the part of the actors. The first actor is, as you see, the complexity is not cancer, but it's cancers. So we are not speaking just about head and neck or leukemia or lung cancer or testicular, but these are all the cancer classified by the organs. And you have seen that there are different subtypes. So one cancer is not one disease, it's a complex amount of different disease. The second thing is are the patients. As a patient, you are all different. You have different metabolism, you have different way of living, you have different anteriority, different diseases, comorbidities. This is the second thing. The third one are the caregivers. And of course, you have doctors, but you have surgeons, you have other nurses, other professionals involved in your treatment. And at the end of the day, if you want to have a global strategy, you need to have coordination about that, regarding the results, regarding the treatment strategy, and regarding the way you will apply it. And finally, we have the treatments. And we have seen that we have a lot of treatments. But what makes, again, some differences is if you look here, if you have one tumor genome that have abnormalities, this is, for example, a mutation in one receptor, you will use one pill, you will treat, and theoretically, it could work very well. The point is that if you are using one drug that you give to treat other type of cancer, for example, colon cancer with irinotecan, you will metabolize this drug. And the metabolism of this guy might be different from the metabolism of another guy. That means that the active compound might be in different concentration, more active, less active, and regardless of the fact that it's not a targeted treatment. So what makes personalized, it's not only the tumor, it's also the patients and the patient metabolism. And then you have to take the decision. This is a multi-parametric process resulting in decision using these 4 different, I will say, parts of the global strategy. You probably know this film. This is the Seventh Seal of Ingmar Bergman. And this is a crusader playing a chess party against death, okay? And this was when I begin my let's say, medical oncology, when I've done my first presentation, I've used this to say, okay, this is what we're doing every day. So this was 20 years before. And actually, when I was thinking about that, probably the situation has evaluated. The first thing is that, like a caregiver, I'm not alone. And as patient, you're not alone. So this is what happens at the hospital, okay? This is the first thing. So that makes the situation more complex. But what makes the situation even more complex is, as a doctor, you don't have just one patient. You have plenty of patients. So this is what you're doing in every day. So you need help. And how to apply this help in everyday practice, I will continue with the chess allegory. We have always tried to just identify that the machine will do better than the human being that you see here, but I'm not sure that the solution is this way. It's not the machine against the human being. It's the machine with the human being against the cancer, which makes a difference. It's why we need some modern tools and some modern approaches. And this is what was calling the personalizing cancer care in ASCO 2009. And of course, personalizing cancer care means 4 things in personalizing. The first one is prognostic. How is prognosis? How is the aggressiveness of the disease? The second one is a prediction. How I'm sure that the treatment will work. The third one is a prevention of not having cancer, of course, but also prevention of controlling the disease and controlling the side effect of the different treatment that you will apply. And the 4th P, which is particularly important, is what I call the participatory. You could not do that if you don't have a network with the patient and also with the other caregivers. It's impossible, because you are not just simple pieces of chess that you put here and you treat. It's more complex. So, I don't know how many time I have. 10 minutes? It's okay? Okay. So this is the second part now. And I would like to take some example and to try to show you how was the evolution of the personalized medicine. And this is just a very simple, that you have probably seen before, picture showing you what we call in oncology, in modern oncology, the driver and the passenger alteration. What does it mean? If you try to explore what are the different mutations that you have on the tumor, you might find 100 of mutation or 100 of alteration. The point is that they are not with the same level of importance. Usually, if you have chance, one is what we call the driver, this one. And if the driver is targetable, then you probably win, because if you shut the driver, you will probably just shut the cancer or better control the cancer. Then you have the passengers. And sometimes, and at the beginning, we're thinking that the passengers are mutations. So if you target the passengers, it will stop the car, the vehicle. The answer is no. Sometimes it might be interesting, but in the majority of the cases, no. So we need sometimes an amount of information, but how to select among this amount of information what is the crucial one that we need for treat the patient. So this is the first message I want to give you for the modern oncology. You can have millions of tests. If you don't have the interpretation of the test, it's like you don't have tests. This is very important, okay? So, example of driver alteration. I will take the first one, the chronic myeloid leukemia. The chronic myeloid leukemia, and you will see the evolution of the technology, was first described has an abnormality with a translocation of chromosome here between 9 and 22. Then, with new technology, we have identified that this translocation is coding for a new protein called BCR-ABL. And with new technologies, we have found that this is an activity of tyrosine kinase. And then, we just define, this is a new protein, how it's possible, potentially, just to block the protein with a drug called imatinib. Before imatinib, the median overall survival of patients with this disease was less than 1 year. Since imatinib, they have the same life expectancy that the patient or the people that do not suffer from this disease. This is a driver alteration, okay? This is clear. You might have some resistance, but this is a driver alteration. You block, but you have a very simple history and very clear. Historically, chromosome alteration, protein, protein function, you inhibit, okay? Interestingly, in some parts of gastric cancer, what we have called some sarcoma, called GISTs, we find that some of them have also this protein. And we're thinking that because they have the same protein, using the same drug will give exactly the same result. And it was not so bad. Not exactly the same, but not so bad. Because as you see here, that about 90% of them have this expression of protein. Before imatinib, the 5-year overall survival was close to 35 to 65%, depending on the staging. And the response to chemotherapy was less to 15% of the patient. Interestingly, we know that this is an activating mutation with a tyrosine kinase receptor, but there is also, we find, another type of receptor that might be implicated in this type of cancer, which is a PDGF receptor, alpha. This is what happens when you historically have treated patients with GISTs. We already know from many years, even before the knowing of what is a genomic alteration, that the wild type that we have here, that some GIST that are clearly on the duodenum or jejunum do not have exactly the same prognosis that the other one that are on the gastric. What we have found is that the gastric GISTs have different alteration comparing to the duodenum and jejunum. So that doesn't mean because you have new tools that you have to let the old one and the history apart. Because history will give you some very important information that will help you to better identify what might be the difference between some type of cancers. And then what we have found is that this is more aggressive comparing to this one that was less aggressive. This was historical data. And this was more aggressive because when you look at the chromosome and you look here at the different portion of the chromosome when you might have the mutation, this one is more sensitive to the classical drug that I mentioned before, imatinib, and this one might be more sensitive to other drug, but less sensitive to imatinib and more resistant. So the aggressiveness was one part of the explanation regarding the difference. But what makes the situation more complex? This is a patient with a GIST. You see here the tumor. And when we have provided the biopsy, we have seen that in 4 different pieces of the tumor, we have 4 different types of genomic alteration. That means that if you treat one part with one strategy, it will work. But when it do not work well, then you have to just test again the patient and discuss if you have to change the strategy. If you just say that the patient is resistant, you will stop here the treatment. If you assume that the patient was sensitive to one, but probably is with different biology on another part, you will try to identify the other part. This is, again, personalized medicine, okay? Lung cancer. We know now that you have 2 ways to have lung cancer. The classical one, I will say the smokers, more than 90%, when the RAS signaling pathway is activated by RAS mutation, which is what I mentioned to you. RAS mutation means be still alive. So if you say to a cancer cell, be still alive, it's very complicated and difficult to kill the cancer cells. But you have another signaling pathway that will provide some cancer, which is a mutation on one receptor called EGFR receptor. And if you have this mutation here, usually in non-smokers, you will have potentially the same type of cancer, but not the same regarding the evolution and the way you will treat it. And what happens? At the beginning, when we have just the microscope, we are describing different types of cancer, but the treatment was exactly the same out of the small cell cancer. Exactly the same chemotherapy, exactly the same strategies, okay? Then among the adenocarcinoma, that was the main subgroup of lung cancer, we have identified some generation. The first one was the rust in the smoker. Okay. Unfortunately, we don't have actually something to use out of immune therapy, which is not targeting actually the tumor, but which is helping the immune system to say, okay, you could not target these tumor cells. They will still be alive, but help the immune system to just kill these cells using the fact that they will recognize this as a non-normal cell, which is another way of personalized medicine, not targeting the tumor cells, but helping the immune system. Then for the non-smokers, EGFR identification and a lot of other identification. MEK, ROS, ALK, RAF, HER2, that are actually all potentially targetable with different diseases. So you see that the majority of the adenocarcinoma are still without particular target, but any case, we still have now a proportion of patients that might have not a life expectancy of 6 months or 1 year, but sometimes 3, 4, 5, and even more years with metastatic disease. And we characterize very well the different mutations that we have. The point is that characterizing this mutation, I will just go here, we have identified different subtypes of adenocarcinoma called EGFR mutated, RAS mutated, or ALK translocated. Using different treatment strategy, tyrosine kinase inhibitor, MEK inhibitor potentially here, but with more actually immune system, immune targeting therapy, and ALK inhibitors. The fact is that we have to define how to identify the alteration, which is really very important in everyday practice because we have small biopsies. What are the priority to identify the different alterations? And sometimes when we ask the patient to have a new biopsy, it's not just because we want to know about science, it's because there are potential very important implications regarding the treatment strategy. And the second one is that we have learned is that when you treat the patient with the targeted treatment, sometimes these are the first publication of patients that have been treated with drug, they became resistant and we find new alteration that you see here. And one of the new alteration is a new mutation on this, let's say, receptor that was not sensitive to the first generation drugs. So we have developed second generation drugs that makes the drug more effective here on these mutations. And this is why the future is also to monitor the way you treat the patient. If you have one alteration here, and if you know that there are some DNA that is circulating on the blood, you will capture the DNA at the beginning, you will have some information, then you will treat the patient, and you will follow with different, let's say, blood samples, and at one moment you will have emerging abnormality. That might be this mutation. And then it will be information, it's time to change, even if you don't have progression when you look at the patient. But this is the way the personalized medicines will be also involved in some cancers. Okay? So the driver mutation alteration are involved in tumorigenesis. They are key treatment if targetable, and resistant clone selection is possible under treatment exposure. The second thing is what I call the oncogene addiction or genomic alteration as predictor of non-targeted treatment strategy. There is one example in the colorectal cancer when there are some alteration, the microsatellite instability, when you have deficiency, that will increase the mutation rate, okay? And what we have learned is that this is usually in patients that are less than 60 years, And we have found that about 15% of them have hereditary mutation, which is called the Lynch syndrome in very, very young patients. But 85% of them have somatic hypermethylation of this MLH1. This is giving the microsatellite instability. Even if it's only on the tumor, it gives a very high rate of mutation on the tumor. And what we have learned is that this is more frequent for the cancer, colorectal cancer in young patients, less than 60 years. And what we have also learned, I will put it here, is that with the classical treatment, when you use 5-FU, there is no effect, no benefit. It's even deleterious. So it's a predictive information of non-interest. But the outcome is usually better. And for stage 3, there is no influence of the treatment. The new thing is that because there is this very high rate of mutation, there are some data that have been published 3 or 4 years before showing that if you have this alteration in a metastatic situation and you use immunotherapy, because you have the high rate of mutation, you will have a very, very important impact. And here you have on the slide what is in red on the late stages and the early stages of different cancer, the frequency of this alteration, not only in colorectal cancer as you see here, but also in endometrial and other one. So having the information of MSI or tumor burden mutation is very important for the future of immunotherapy. That means that you probably might tomorrow select population not according to the type of tumor, but just to the tumor burden mutation. So this type of alteration are not targetable. They are sometimes involved in tumorigenesis, as I mentioned in the Lynch syndrome. They might help to better define the prognosis, but they might help also to better define the prediction, and usually the prediction of the treatment that are targeting the environment of the tumor, but not directly the tumor. So now the passenger alteration. And you have seen that the passenger alteration is the biggest part. And I will just mention this paper that was signed last year by Joseph Tabernero, which is the president of the European Society of Medical Oncology, just showing how complex when you have to give some information, some result to a patient, you have to integrate a lot of information to say at the end, I have this type of mutation, so does it matter or not for the patient? How to treat the patient? Because if you ask for a test, and if you don't know how to use it, why you ask for the test? Okay? And the point is that you as patient, of course, you want to have all the possible answers, and sometimes a lot of tests. But if you have the test, but do not have the answer of the test and how to use it, you will just spend money without the clear information you need to help you to better build the strategy of the treatment. So the passenger alterations are the most frequent. They are usually multiple, and they might be interesting if involved in specific pathway, as I mentioned before in RAS, but they need expertise, clearly. And this expertise is to define clinical relevance of what this mutation or alteration means. So now the question is how to implement personal medicine in practice. This is the last part, and I have just a few slides. And the only way to use it is integration of the modern tools in tumor boards. And the tumor boards of the future are not just discussing with the pathologist. Of course, you have to discuss about the pathology, but you have also to look at the circulating tumor cells potentially, the analysis of the imaging, the genomic data, of course the patient, etc. And this integration of all this information takes a lot of time. So the more you have information upfront with the analysis of the information, the easier it will be to give the answer. What does it mean? It means that what are the innovative and indispensable tools, what we think? And this is what I think for the patient. The first is that they need to be validated, reproducible, interpreted, and fast molecular diagnostic tests. Okay? If you ask for a test and you have the answer 6 months after, it's too late. We can discuss about the prevention, but the treatment 6 months is too late. Okay? So when you look at the genomic alteration of the, not somatic, but the germline mutation for BRCA, you might wait 6 months just to know if you have to do some prevention surgery or how to identify in the fratry, in your sister, your kids, any problem. The second thing is that you need access to innovative and targeted therapies. Because if you have the information, yes, you have a driver, but you don't have the molecule, it's an awful frustration. First for you, second for the oncologist, of course. So you have to build a strategy. And the third point that is very important is that the access to innovation and targeted treatments is also optimization of access to therapies under evaluation. That means access to clinical trials. If you don't have access to clinical trials, if you don't have access to new therapies, you can spend a lot of money to have a nice picture of the tumor, but if you don't know how to treat it, that's the problem. And the last thing, which is, of course, the first one, it's the clear and honest information delivered to the patient. Because as a medical oncologist, you need to just explain to the patient that, yes, you might have some information. Yes, some might be relevant, but some might not be. And even in the relevant one, you're not sure that you might offer these therapies because it's not accessible in your country. Or you might then ask the patient to enter a clinical trial, and he had to be prepared. If the patient do not want, then why you do the test? Okay? I will give you 2 examples of 2 of my patients. I've received the test a few days before, just to this is for the maybe some doctors are here on the audience. A 64-year-old woman. She had, at the time of the diagnosis, a bilateral breast cancer with liver metastasis and lymph node metastasis. And the cancer were different. On the left side, you see here, it was a luminal estrogen receptor positive, HER2 negative. And on the right one, it was estrogen receptor negative, HER2 positive. So we decide to treat the patient with the treatment that will apply to the most aggressive tumor, because the prognosis is due to the HER2 positive disease. So we have targeted with double blockade with pertuzumab, trastuzumab, chemotherapy, and followed by maintenance aromatase inhibitor plus a double blockade because the other tumor was estrogen receptor positive. Then after a few months, we have some residual tumor on breast, and it was operated. On the right side, she was in complete remission. On the left side, she had a residual tumor with a small tumor of less than 2 centimeters and 1 positive lymph nodes. But she had also residual liver metastasis. And because the result was very good, and I was not sure that the residual liver metastasis was HER2 positive or HER2 negative, we have done a surgery on the liver. And the patient was operated. You see here, estrogen receptor 70%, progesterone 0, HER2 2+, but FISH negative. So she was HER2 negative. And this was considered to be the metastasis of the left breast, estrogen receptor negative. Then we have done a foundation medicine test, which might be another one if you want, but in any case, a test. And this test was received not so far, 1 week before. And you see here what we have, the information, just to give you the different important points. First, microsatellite status. You remember what I mentioned to you, the MSI, stable. So no discussion about immunotherapy. The second thing, tumor mutational burden, low, not too much. Probably not a good candidate for immunotherapy. We ask that because we have some trial actually ongoing with immunotherapy. In case she will have a progression or relapse, she might be included in. Out of that, we could not treat the patient because there is no drug reimbursed actually in this situation in France. Then we have several gene alterations, and you see here that we have PIK3CA, MYC, CHEK2, SMAD4, and P53. And there are 3 relevant genes with no reportable alteration. HER2, no mutation, no amplification, BRCA1 normal, and BRCA2 normal. That means that the classical one that you might have in breast cancer, and that might be very important to target, are not present. It's normal. But among them, some are drivers, potentially, and the other one might be, let's say, passengers. And among them, we have two interesting. One is PIK3CA. And for the PIK3CA, if you remember the two pathways I mentioned to you, RAS is to survive, PIK3 is controlling the proliferation and apoptosis also. There are actually drugs that are targeting PIK3CA. The mTOR inhibitor are targeting the pathway, but alpelisib is a new drug that is actually potentially accessible in France. So that means that at the time of progression, I can use it. Yes, in 2 minutes I will finish. The second case is a 61-year-old woman. And you see here she was treated in 2008, first of all for breast cancer, then in 2012 for an adenocarcinoma of the lung, and she had a relapse and a bony disease in 2016. And my colleague who is taking care of lung cancer was convinced that it was a metastasis from the lung cancer. It was not. It was a metastasis from the breast cancer because when we have done the biopsy, it was estrogen receptor positive, HER2 negative, and no argument to say that it was a lung cancer metastasis. The patient is actually a doctor, immunologist. She had received a lot of treatments in the last 3 years. She had continued to work. And recently, she had a very rapid evolution with liver mets. She was in a very bad condition, let's say, 1 month and a half ago in our department. And we have done liver biopsy urgently, just to characterize a tumor. It was necrotic one. So it was impossible just to have any clear relevant element. So I asked, the patient was hospitalized for hypercalcemia, and I asked for liquid biopsy and received the result yesterday. This is 17th of June. I was just at the airport waiting for my flight for coming here. And this is the information I get from the liquid biopsy, okay? MSA status undetermined, so it will not help me. I don't have the information. But she had a mutation on HER2. 2 to 3% of the breast cancer had HER2 mutation. And they are very sensitive potentially to trastuzumab or lapatinib or neratinib. So that means that actually, I know that she is answering to chemotherapy, which was weekly paclitaxel, but will probably had anti-HER2 treatment. And these are the MSA status are undetermined and the different type of treatment that you might apply. You see here, this is the report that you have. So at the end, what innovation means? One, that if you want to be innovative, it's not my statement. This is for the Harvard Business Review. As a medical oncologist, sometimes I'm reading these kind of things that are interesting. So first, you can be, if you want to be innovative in your department, tolerant to failure, because everyone might fail, but you need to be optimal regarding the competence with regard to expertise. You need to do your best, even if you do not succeed. This is the first thing. The second one is the dynamism of experimenters is, of course, very important for innovation, but in a rigorous framework, don't do the testing without tumor boards, without thinking about the strategy. This is the message. Psychological security, but frankness concerning the way you will discuss with the actors, that means, of course, with the patients, what we might expect and what are the limits. Collaboration, but maintaining individual responsibility. That doesn't mean I have just applied the results and I'm not the actor. I'm just applying what we have to do. As a medical oncologist, I have to decide if it's relevant or not. And finally, a non-hierarchical but strong leadership, because you always need to have, in this approach, someone who knows a little bit more than the other one. So precision medicine in oncology is part of the personalized medicine and probably the future of oncology. However, it needs access to quality testing, access to innovative drugs, to clinical trials, and moreover, patient implication and education. This is just to mention that we have, in October, the 4th AROM meeting, which is on Montenegro. It's the 4th edition, and we have the 3rd consensus conference concerning the access to innovation that will be, the last two will be published in a few weeks, and we want just to define how to access innovation in countries with limited resources, and I thank you.